Hello EMT students, how's everyone tonight or today, whenever you're actually watching this. The next section in our trauma division, we're going to talk about musculoskeletal trauma. And tonight we're going to review the musculoskeletal system, anatomy, and physiology like we discussed a couple weeks ago. We're going to talk about the types of injuries that can occur to the musculoskeletal system and what signs we'll be looking for, and then what treatments we can provide for that. And at the end, I'm going to show you a few x-rays that have some sample fractures and things like that on there. So, sip of coffee and we'll get going. So, physiology. The musculoskeletal system for us provides support and shape to our bodies. It protects us. The bones protect vital organs. It allows for movement. In some of our bones, we produce red blood cells. And so let's talk about the bones, the framework for the body. And then obviously we have joints which allow us to bend and muscles that allow us to move. So we have bones. We'll talk about those extensively here in just a little bit. We have cartilage. And where do we find cartilage? Again, cartilage is found at the ends of bones and between bones. And so it's kind of like a cushioning effect. We have ligaments, and those are tough fibrous bands of connective tissue. And where do we find those? They go from one bone to another to help give us structure for our joints. And we have tendons. And where do we find those? And again, tendons go from a muscle to a bone. So when the muscle contracts, the tendon is attached to a bone and makes that bone move. So, bones. They're formed of very dense connective tissues. And as we mentioned before, they're also a repository for ions. You know, obviously there's a lot of calcium there, but other ions are housed within the bones, and it's a constant dynamic process. You know, calcium ions are entering the bones and they're leaving the bones, as well as chlorides and sodiums and all sorts of other electrolyte ions. Bones do have blood vessels that go through them. And so when the bones break, not only can we have bleeding from the soft tissues around the break, but we can have bleeding from within the bone as well. And again, remember, bones are covered by periosteum, peri meaning around, os meaning bone, condition of being around the bone. And again, how many bones do we have in the human body? 206. Give or take a few little tiny sesamoid bones in our feet or somewhere else. So again, you need to know the names of the bones. We've already provided you with that. This is just a graphic that was in your book that you can look at. It's so much easier to read than it is here on this presentation, obviously, so we're not going to dwell on this, but you do need to know the names of the major bones. So we can classify bones by their shape. We have bones that are irregular. And those would be, as an example, bones of the spinal column. We have long bones, like in our extremities, our upper arm bones, the humerus, radius and ulna in our forearms, femur in our upper legs, tibia and fibula in our lower legs. We have short bones, like the bones in the hand, okay? The carpals, the phalanges. And then we have flat bones. Flat bones would be like the sternum, the scapula, or shoulder blade. And just a couple of terms that I don't think are in the book anymore. As a matter of fact, I'm pretty sure they're not in the book anymore, but you may hear them as you talk to people, especially in the medical field. But the shaft of a bone, we're talking about primarily long bones here, but the shaft of the bone, the main cylindrical part of a bone, is called a diaphysis. And then as you go towards the end of the bones, we have a short neck area in some of these long bones. And that area of the bone is called a metaphysis. And then at the very end of the bone, we call the epiphysis. And as we're children and we're growing, the epiphysis is not actually attached to the metaphysis. There's a space there. And that's where the bone grows from. I actually have a picture of that. I'll show you towards the end of the presentation. So you may have children, you may have had children, or no kids, that have had a fracture in the epiphysis. It's called an epiphyseal fracture. And that's a fracture through the growth plate. And that could be pretty serious because it could stop the bone from growing. We call it arrested growth. And they may have to have electrical stimulation and things like that to get those cells to start to duplicate and grow. So the shaft is a diaphysis. Towards the neck of the bone is a metaphysis. And at the end of the bone, we have the epiphysis. Again, periosteum goes around the bone, and the center hard part of the bone, not the center of the bone, but like where the diaphysis is, we call compact bone. And then as we get closer to the epiphysis, the bone is a little more lattice looking, you know, kind of like this. And we call that cancellous bone, okay? So you may hear those terms. And again, examples, irregular bones in the vertebrae, scapula, flat bone, long bone, humerus. Okay, flat bones can be ribs too, short bones, okay? So when there's a fracture, and we'll talk about those in just a minute, the bone has the ability to heal itself in many cases, unless there's some sort of pathology going on or disease process, you know, like bone cancer or something like that. So when a bone breaks, the soft tissue around it starts bleeding and swelling, and a blood clot will form around that fracture. And so when that happens, again, we said bone does have blood vessels. You can interrupt the blood supply, and then some of the bone cells will begin to die at that injury site. Cells that are a little further away will start rapidly dividing to start forming new bone tissue. And what happens is that periosteum, a little ways away from the fracture site, will start growing and go up over that blood clot and all around it, because it's three-dimensional. And then the new bone starts going in there and starts getting deposited. We call that formation of bone around a fracture site a callus. And eventually it'll be like a ball of bone around that fracture site, maybe it's a small fracture site. You know, if it's a humerus or femur, it could be a decent size ball of bone, if you will, in that callus. And over time, especially if the fracture occurred when we were younger, the body starts to mold away that ball of bone so it's more in an anatomical shape. And so, you know, you could have a child that had a fracture when they were 4 or 5 years old, and you take an x-ray when they're 30 and you can't even tell if they had a fracture. If I were to break a bone and 10 years from now take an x-ray, you would still be able to see the fracture because I'm old, right? All right, we also have muscles, of course. Skeletal muscles is what we're going to be talking about tonight. Smooth muscle, which is involuntary, things that tell our gastrointestinal tract to keep moving and move that cheeseburger down the line. Or they're inside our blood vessels, changing the diameter of the blood vessels, depending upon whether we're sitting, running, standing, jumping, whatever. And then the third type of muscle is cardiac muscle. We'll talk about that down the road when we talk about cardiac emergencies. And then, of course, the cartilage helps form flexible structures so that, you know, we can have joint movement along with the ligaments, and, you know, the cartilage slides together so the bone ends aren't grating on each other. So unless you have a problem or you've torn your cartilage. Tendons allow for power, okay? And again, muscles go to a tendon that goes to a bone. Okay, so tendon to bone. All right, but it starts with muscle. And again, most everybody knows where their Achilles tendon is, and it's easy. It comes from that gastroc muscle or your calf muscle and goes down to your heel bone. Ligaments support the joints because they go around the joints, or around where the bones come together to form the joint. And hopefully they stay tight and they don't get torn, and they make it for a stable joint. So again, it goes from bone to, and then we have our ligament and goes to another bone. And the picture that shows that, I don't know if you can see my cursor, but these are the collateral ligaments on the outside, okay? And this is a left leg or a right leg. So this would be a medial collateral ligament, MCL, okay? And this would be a lateral collateral ligament. Here's the crisscross ligaments in the center, and those are the cruciate because they're like a cross, crucifix, cruciate, okay? And the one that's in front is the anterior cruciate ligament, or ACL, and the one in the back is the posterior cruciate ligament, posterior cruciate ligament. Muscle coming down from our upper leg goes to a tendon, and actually the tendon goes right around this kneecap, the patella. The kneecap is resting inside a tendon. It's not attached to the femur, just the distal end of the femur at all. It rests inside this tendon, and we call it the patellar tendon. Patella is kneecap, patellar tendon. So, guidelines for care. First of all, we talk about mechanism of injury. These aren't sick people, these are injured people, so it's mechanism of injury and not nature of illness. So we have different forces. We have a direct force. So that's where something actually strikes somebody, so to speak. For example, someone took a hammer and hit me in the forearm, and I break my forearm. That's direct force. Then we also have indirect forces. Indirect is a force is transmitted from where it first impacts the body to another place that then causes a fracture, like a weak spot or something like that. An example of this is somebody that fell off a ladder but landed on their feet, but they break their hip. The feet didn't break, but their hip broke. A worse example would be somebody that dove into a pool and hit their head. They don't fracture their skull. What do they break? They break their neck. So indirect force. And these could be blunt trauma, again, forces that don't cause open injury to the skin. And then we have twisting or rotational forces. The best example of this is somebody that's skiing and catches a ski and twists their leg and then breaks their leg. Football players, twisting forces, that's how their MCLs and ACLs and things like that get torn, because somebody grabbed their legs and twisted them somehow in many cases. All right, so a fracture is any break in a bone. Sometimes people say, yeah, I chipped my bone or I cracked my bone. We just use the word fracture. It all means the same thing. The continuity of that bone has been interrupted due to trauma, injury, okay? Fractures can be open or closed. And by open, what we mean is that the bone end is actually protruding out through the skin. Closed means it's not protruding out through the skin. And one of the things I'll mention again probably later is that sometimes you'll have a hole or an open area over the site of your suspected fracture. That probably meant the bone came out and then slipped back in. Open fractures are nasty. One, they look bad. But two, they're a big opportunity for the body to get contaminated. There's a lot of germs on our skin. Our skin protects us very, very well. It's the best protection we have. But when you break that barrier and that bone goes out, it's in the environment, picks up bacteria and Lord knows what else, and then it slides back in. It takes all that bad stuff with it. And it's very, very common for people to get infections. They can also get a bone infection, not just skin infection around the area. And the bone infection is called osteomyelitis, in case you hear that word. If the bone end is out, we're going to leave it out. We're not going to let it slip back in. You know, we don't want to have that happen. But it may have already gone back in as the patient moved around. Different types of fractures. Comminuted means it's broken in several places. This is usually some sort of a crushing injury mechanism. Somebody got caught between two cars, bumper to bumper, and crushed them a little bit. Actually, I have a picture of that for you later. But the comminuted means the bones are in pieces where the fracture is. Green stick is a type of fracture that children get because their bones are very pliable still. They don't have a lot of the calcium deposits in there like we do at our ages and your ages. So a green stick is just like it sounds. You take a green stick and you bend it, it frays, and then might even go back down, but it doesn't go all the way through. It's a partial fracture. Lots of times, even on x-rays with the kids, you really can't tell that there was a fracture there. They'll put them in a splint, tell them to come back in 7 to 10 days for another x-ray, and they x-ray them again, and they'll start seeing that new bone being deposited, and they'll say, yep, that was a fracture. So green stick is an incomplete break. I actually have a picture of that for you towards the end as well. Then we have fractures can be angulated, bent at an angle. So they're not, the bone is not in its anatomical position like it should be. It's off to the side for some reason. We call those angulated fractures. These are things you're not going to necessarily see, but you may hear these terms, you know, around the hospital or as you're transporting patients. But transverse fracture is a fracture that goes straight across, horizontally across that bone. Straight across fracture. Another type is an oblique fracture where it goes at an angle. And I think I have a picture of that for you at the end too. And then we have spiral fractures that would come from that twisting or rotational force, like the skier we mentioned. And it kind of like, there's a crack that kind of circumvents or goes all circumferentially around that bone. We also have pathological fractures that are caused by a disease process. Pathology, pathogens, disease. Okay. Pathological means it's caused by a disease. And there's different types of conditions out there. You could have bone cancer. You could have that osteomyelitis. A lot of the older folks have osteoporosis, where the bones are becoming porous. Porosis, bone porosis, porous. And it's easy. A lot of times we'll have patients that complaining of hip pain because they fell. They fell and broke their hip. Well, a lot of times what we're finding out is they got out of bed, stood up, and because of their osteoporosis and weak bone, their weight caused their hip to break and then they fell. Not that it matters, we're going to treat them the same way. But people don't always fall and break their hip. Sometimes they break their hip and then fell. And again, fractures can be closed or open. And the former term for open fractures was compound. So if you've ever heard the word, this person's got a compound fracture, that means the bone came out of the skin. Or if somebody doesn't know what they're talking about and says the bone's broken 2 places, so it must be compound. Nope. Compound was an older term for open fracture. Open makes it much simpler. And again, if there's a wound over that suspected fracture site, then it probably was an open fracture and the bone receded back inside. Here's an example of a closed fracture just above the ankle. And that's in your book. There's a lot of good pictures in your book, by the way. They're not all in this presentation. All right, so other things can happen when you have a dislocation, which is coming apart of a joint. There's also something called a subluxation, which is a partial dislocation. The joint doesn't come all the way out. Shoulder dislocations are very common. Hip dislocations are not common, but they do occur. Subluxations, it's hard to tell. Those are the ones where if it's in a shoulder, their arm is stuck like this and doesn't move. If it's a total dislocation, their arm is down to the side and they're leaning that way. That would be a dislocation. And when you palpate and you follow the clavicle, instead of the shoulder head of the humerus, the top of the upper arm bone being where it is on you, it's actually here. And you can actually feel it. So when you're palpating the chest and you go up towards the shoulder, you're going to feel that lump. And that's an anterior dislocation because it's coming forward. Posterior dislocations, because they fell on an outstretched arm and pushed their shoulder out that way, then you're going to have a lump towards the back. Okay. A subluxation for shoulder, more than likely, it's stuck halfway in between. And so their arm is stuck somewhere. And those are probably the hardest things to treat because it's really hard to put a splint on them and keep them immobile. Another subluxation, some people have, it's called TMJ, temporomandibular joint disease, where their jaw tends to dislocate, but it actually subluxates and gets stuck. You know, they go to take a bite out of an apple, big bite, and all of a sudden, boom, they got terrible joint pain in their jaw, and it almost feels like a lockjaw. That's because part of that mandible, okay, the lower jaw, came out of its socket and it's stuck there. Not fun. I had that many, many years ago. It is not fun. And I was eating an apple. Sprains, and that's a stretching and tearing of ligaments. So a sprained ankle, they torn the ligaments, okay? If you tear muscles, we call that a strain. So a sprain is stretching and tearing of ligaments, and a strain, very similar words, is overstretching of muscles. Okay. So not all injuries can be confirmed as a fracture. We don't have x-ray vision. We can't always tell if something's broke or not. I mean, there are some that are obvious. We see the bone end sticking out, their forearm is off at 90 degrees, things like that. But just because they're painful, swollen, and tender doesn't necessarily mean it's broke. Could be just soft tissue injury. But the whole thing is we're going to treat them as if it is broken, okay? So, assessment. The first thing and foremost is we want to rapidly identify and treat life-threatening conditions, okay? Be alert for injuries besides this grotesque looking musculoskeletal injury, so you got this leg off to the side and it looks, oh my God, or they got bone ends sticking out. We don't want to get tunnel vision and focus in just on that. Okay, we call those distracting injuries. They distract us from total patient care, and that's a bad thing. Life threats come first, always, always, always. And you're going to need to cut or remove patient's clothing to complete an exam, again, if it's appropriate to do so. For example, you're never going to put a splint on someone's leg over top of their jeans. Jeans come off or get cut off, okay? The same with bandaging. Bandages don't go over clothing. They want us to talk about something called compartment syndrome. There's a couple different versions of this. The one we're talking about now is for trauma. But if you have usually a pretty significant blunt force trauma to an extremity, it can cause something called compartment syndrome. Now, the muscles in our extremities run in what we call muscle bellies. And so you'll have areas of muscle, and around that muscle is like a connective covering, so to speak, connective tissue covering. And you could have we have several muscle bellies, okay? They go down and they work in conjunction with each other. But if you have a significant blunt force trauma, you can cause swelling of that muscle inside that muscle belly, and you have a collagen connective tissue that's surrounding it that doesn't allow for much expansion. So if it's bleeding in there or towards swelling, things like that, it's going to cause pressure inside that muscle belly. So whether it's a fracture or not, it could occur. So there's swelling in the extremity, and it becomes so great that the body can no longer push blood through and perfuse, make sure all the blood gets there, perfusion to that muscle. And it becomes incredibly painful. And because it's in a muscle belly, the tendons, let's say it's your forearm, and it's in the muscle belly, the tendons start in here and go, all these things that make your fingers move is your forearm. Do this, put your hand here. Do you feel all those muscles move? You can feel different areas, so there's different muscle bellies, okay? Moving like this with a muscle belly that's under pressure, it's not getting perfused with blood, is terribly, terribly painful. And that's one of the ways that you just move a finger and they jump with pain here. That's compartment syndrome. Now, some people can get compartment syndrome because of pathology. They just get it because, for whatever reason. And so that's a medical type of compartment syndrome. But we're talking about when it's coming from a trauma, an injury. So damage occurs, blood flow to the area is lost, and they could lose their limb from that because all that muscle tissue in that belly will die. So overall patient care, we perform a scene survey as always. Okay, then we do the primary assessment, which is our look for immediate life threats. During a secondary assessment, based on the mechanism of injury, if you think the spine may have been injured, spine injuries is the next lecture, we're going to have you apply what we call a cervical collar. It goes around the cervical vertebrae, the neck. Cervix means neck. And to help start to protect that area of the spine. So, assessment of musculoskeletal injury. Some of the things that we're going to discover as we're assessing our patient. First and foremost is pain and tenderness. Okay, pain is what they're telling us. Tenderness is when we palpate them and they go, ouch. Okay, that's a sign. Pain is a symptom. That's obvious. You break a bone, you damage soft tissue, there's nerves everywhere, it hurts. You may see a deformity of some kind or an angulation, okay? This is one of my favorites. It's called crepitus. Crepitus is a grating sound of like broken bone ends grating together. And you can, not only can you feel it when you're taking care of somebody that has that loose fracture site, you can feel it as well. So it's a grating or sensation or sound. You can actually feel it and hear it sometimes. Obviously, swelling can be present, and not all of these are on every fracture. Okay, these are some of the things you could see that'll clue you in that it could be a fracture, or you're going to at least treat it like a fracture. So again, if the bone's broken, even just with the mechanism of injury, there could be a lot of swelling around that area. There could be some significant bruising. We're not talking about just a little tiny bruise. We're talking about a pretty decent sized bruise. And the word for bruising is ecchymosis. Ecchymosis, so black and blue, ecchymosis. And if you have a decent sized bruising, that means a fairly significant amount of blood's probably leaking from that fracture site and the soft tissue injury right around it. You may see exposed bone ends. Again, leave them out. You may have joints locked into position like with the shoulder I mentioned. You might see something I call false motion. If you have an unstable fracture and you go to move, and let's say your fracture is here, okay, and you go to move your arm this way, this part of the arm moves that way, but this part of the arm comes back this way. So it's like moving in opposition, and it's not totally dissimilar from the paradoxical motion, you know, that Rob was talking about with flail chest injury. The best way, and don't be offended, I can think about doing this is you're watching girls playing volleyball at the beach, and they jump up to block a shot, and part of their body actually moves down, and then when they come back to the sand, part of their body moves back up. It's moving in opposition. Okay, that same thing happens with extremities. You'll go to move an extremity. If you're not careful, you'll see it flop back, and then you know you have a very unstable fracture site. Limb rotation, I put this in because, excuse me, the classic presentation for somebody that has a hip fracture is that their leg will be, pretend these are their feet. On the side of a fracture, it'll be shortened and externally rotated. That's classic for a hip fracture, okay? So if you come across somebody who's got pain in their hip, don't know if it's broke or not, look at their feet. Their knee may be up on the fracture side a little bit, but again, it'll be shortened and externally rotated. If it's a hip dislocation, which is not common, it'll be internally rotated, okay? So classic, and quite often you'll see this as a test question. What's a classic presentation for a hip fracture? Limb is shortened and externally rotated. Also, when you're assessing, obviously we do our pulse, motor, and sensation checks on all four extremities. So we're looking for blood vessel compromise, nerve compromise, okay? So you may have decreased sensation. They can't tell you what finger you're touching. You may have decreased pulses, okay? They may not be able to move their fingers, for example, very well, or very feebly, you know, or you go to have them squeeze that one finger and there's hardly anything there compared to the other side, which can squeeze very well. And we always compare left and right sides. We're doing PMS stuff. And they could have that pain and classic presentation with compartment syndrome where they, you move their fingers and there's terrible pain in their forearm type of thing. 6 P's of assessment. I left this slide in here, but talk about some of it. But pain or tenderness, obviously. Pallor is pale skin. Okay. So distal to a fracture site, if there's enough swelling that blood supply is being cut off, distal to that fracture site, the skin will be pale because it's not getting enough blood supply. Pins and needles sensation, which means there's pressure on a nerve. Okay, we call that paresthesia. That's something I have constantly because I've got a couple herniated discs in my neck. I'll actually probably show you a picture of that next lecture. So I have constant pins and needles sensation in my arms and hands. And I'll be having surgery here shortly, I'm guessing, not until first of the year. May have diminished or absent pulses, okay, and then paralysis, doesn't move at all, and a feeling of pressure, okay. Oop, what am I doing? All right, so patient care, we're going to splint any suspected extremity fracture after life-threatening conditions have been treated, okay. So again, we don't want to splint somebody to death because it's a grotesque, distracting type of injury that takes our focus away from total patient care, okay? Total patient care comes first, ABCs, mental status, that sort of thing, right? If you have an open injury, excuse me, over a suspected fracture site, obviously you're going to provide sterile dressings to that. Again, not over clothing. You're going to need to expose, you need to be able to see it. All right, so the big thing we do is splint. And the purpose to splint is to immobilize the fracture, okay? Keep it from moving around, okay? So the principles for that are whatever we do, whatever kind of splint we use, because there's a lot of different splints out there. And we'll show you several different choices and ways to do things. And one of the things I like to say is there's more than one way to skin a cat, as long as the cat gets skun, so to speak. So we have principles when it comes to splinting. And the principle is the splint needs to immobilize the site of the suspected fracture, okay? The splint needs to immobilize the joint above it and needs to immobilize the joint below it, okay? Because if we have let's say we have a fractured forearm, and we put a board splint here, something to hold this still, but I'm still doing this, okay, that's moving those bones. We got to mobilize that wrist, that forearm, and that elbow, okay, in some fashion. We want to make sure whatever we put on to immobilize that site is not too tight that it cuts off circulation or impairs nerve function distal to the fracture site, or it's not too loose that it's still allowing bones to move, okay? And this is part of our ongoing assessment that we talked about in assessment. You may have put a perfect splint on, but now that there's swelling, it's getting too tight. So that's why we're constantly doing the ongoing assessment and reassessment, making sure that whatever interventions that we're doing are still working the way they're supposed to. You need to do pulse motor and sensation, or CMS, circulatory motor and sensation checks before and after splinting, and actually before and after every procedure that you do, okay? You're gonna put a bandage on, PMS check, put the bandage on, check it again. Same thing if you're putting a collar on somebody for a neck injury. PMS checks all four extremities, collar on, maybe some other mobilization things, and then you check them again. Make sure nothing's been interfered with. So why do we splint? Well, obviously it minimizes movement of those broken bone ends, okay? We're not skeletons, okay? We have bones, we have soft tissue around us, we have, connective tissues, blood vessels, nerves, skin, a whole variety of things. If that fracture site is unstable and it's moving around, it's chewing more soft tissue, okay? It's gonna cause more pain, it's gonna cause more swelling, may cause more nerve problems, okay? A lot of things like that. So the advantage of splinting someone is keep them broken bone ends still, all right? So we want to prevent that additional injury if those broken bone ends are moving around, all those soft tissues. Obviously, it decreases pain because that fracture is not moving around, okay? It'll minimize blood loss by not interfering with blood vessels that haven't already been damaged, okay? We can prevent a closed fracture from becoming an open one. If we don't splint and that arm's allowed to flop around, that broken bone end may pop out through the skin, and we definitely don't want that. But again, we don't want to splint someone to death. If they're dying because they're bleeding in their chest, I don't care about their arms and legs right now. We'll fix those later. And by reducing, or by keeping everything still and not causing any further damage to the soft tissues and all those other things, you can actually reduce rehabilitation time. If they're allowed to flop around and all that, More damage is going to be there. Could break some more stuff out. You may add infection if the bone comes out through the skin, and that's going to really increase your ability to recover from this injury. So there are situations where we will manipulate a bone. Excuse me. So if we have an angulated fracture of a long bone, it's not involving the joint. So we're talking about in the forearm, in the upper arm, upper leg, lower leg. And it's off at an angle, okay? We're gonna want you to try to straighten that out quite a bit, okay? And there's a procedure for that. When you go to move it, it's gonna hurt them, okay? But it doesn't last very long, it only lasts a few seconds. And once those few seconds go by, their pain dramatically diminishes. They're still gonna have pain, but it goes way, way down from what it was. When you have an angulated fracture, everything is bent. Blood vessels are bent. You're having impaired circulation, which is causing pain. You have impaired nerve function, which is causing pain. It's really not pleasant. I've had several of these. Not me personally. I've taken care of patients that have had these. So we need to straighten it out as best we can. If we don't, and you try to put a splint on the way it's found, all those things are still happening. The nerve damage and, you know, decreased circulation to the skin and other parts of the bone too as well, and could cause further injury. So some guidelines, we don't manipulate a joint injury. So if you see like an ankle that's angulated, we don't mess with those unless there's no pulses. If there's no pulses, you're going to get one attempt to just do some traction and try to straighten it a little bit just to reestablish a pulse, because joints are very complicated and you can really screw some things up. So the only time you mess with those is if there's no pulse distal to that ankle or whatever, elbow joint, whatever it happens to be. So what's going to happen is, one of the things we're going to have you do is hold manual stabilization while you're assessing your patient, you or your partner will. You're going to, let's say it's a forearm. One of you will take the patient's hand, okay? The other one's going to support the site. Again, try to imagine we're off at 90 degrees. And we're going to pull traction while he's holding back this side. And so let's say it's angulated. Now, we don't want to do something I call the scissor effect. Don't just try to straighten it, because then that's not helping much. You're damaging more soft tissue. If this is the distal part, pull traction, and then try to get them as close to aligned as you can. Doesn't have to be perfect. Just get that kink out of there. But you got to pull traction. If you just simply grab it and try to straighten it the way it is without pulling traction, you're creating a scissoring effect, and that's going to damage more soft tissue. Okay. So traction is the key. And so the person on the left is going to pull traction because, you know, she's got the distal end of the extremity. The person on the right, the EMT on the right, is holding stabilization and counter traction, if you will. Okay. It's a tough thing to do. A lot of people don't want to do it. I've gone to calls where EMTs have gotten there before me and they're already splinting it when the thing's off at 90 degrees. And I'm like, no, you need to straighten it out. No, no, no. And then they look and see it's me. You know, it's kind of funny sometimes. But yeah, we need to do that. I had a kid one time, he was playing midget football. It was practice for midget football up by Jefferson on one of the side fields. And he had an angulated fracture about 3 inches above his ankle. And he still had cleat shoes on. And so I'm carefully taking the cleats off. And I sent my partner back to the rig to get the type of splint I wanted. And the kid's dad is there. And this kid he's like 9 or something, young kid. And so I told the dad, I said, I'll be straightening this out before we put a splint on. And the kid starts hollering, no, no. Of course, he's already screaming in pain anyway, because it's off at 90 degrees. And I thought, oh, that was stupid. I shouldn't have said that. So my partner's coming back. with the splint, and he's just about here, so I know we'll be ready in a second here. And so I went ahead and had Dad hold counter traction, and I pulled on the foot and straightened it. And the kid hollers out, and like 3 seconds later he goes, "Oh, that feels so much better." And I was like, "Yeah, bud, that's what I was trying to tell you, you know." And I looked at my partner, and he turned pale, and he got sick. He had never seen that before, and he heard the crepitus when I moved it. So I laughed like heck because I made my partner sick, straightening out a bone fracture. If you go to try to pull the traction and you go to try to straighten and nothing's happening, it feels like it's locked, it's not moving, then you're kind of stuck, okay? But if you're not feeling resistance, you know, pull that traction, and you need to do it fairly quickly. You don't want to take 10, 15 seconds to try to straighten this thing. You want to pull traction and boom, okay? But if you get to here and it won't go anywhere, you're going to be stuck where you're at. So if you get that resistance, you're going to splint it just the way it is. That's all we can do at that point. And again, no scissoring effect. You need to make sure you're pulling traction on that distal part of the extremity. And the final position does not have to be totally anatomical. It just needs to be close to get rid of that kink, to reestablish any blood flow, and to take pressure off of the nerves, okay? And the other thing why we try not to do it with joints is nerves and blood vessels are really close to joints. For example, there's a thing called patellar dislocation where their kneecap goes out of place. And a lot of people say, oh, their knee was dislocated. No, it's not their knee. It's their kneecap, the patella. And we can put those back in place. We're allowed to. Basically go to the outside of the leg on the side that the patella's gone to. It's usually the outside. And you just take your thumbs and then push it back in place, okay? A real simple procedure. But a true knee dislocation, where the distal end of the femur and the tibia come apart, those people, they tend to lose their leg because everything is tied so tightly there that when they do this, they rip that popliteal artery, which is the artery that runs behind the knee, and they rip the nerves, and they can't do anything with the lower leg. They usually end up having to have an amputation. If they don't, and they're working with these people, they're in the hospital for like 3 months trying to make sure this leg stays alive. So a true knee dislocation is extremely serious. But most of the ones where you're going to get a call for a knee dislocation is the patella. And again, hands on the leg, thumbs against that kneecap that's out towards you, just push it up and it'll go back in place. The other thing that you could do, it's not recommended now, but I've done it because, not by choice, but I've had patellar dislocations before we were allowed to put them back in place, where I would take the leg to get ready to put a splint on it, and I'd position the leg to lift it up to go put a splint on, and just that simple motion of moving that foot just an inch or two made it pop back in on its own, okay? Immediate relief for that patient when that happens. So you want to pop those back in. You might need to have some ingenuity. Sometimes you're going to have something that's in a funky position and you can't straighten it, and you got to figure out, how am I going to splint this thing? And that's part of being resourceful, okay, as an EMT. The different types of splints, categories, if you will. We have rigid splints, which are like board splints. We have formable splints, which could be like a vacuum splint, a moldable splint we call SAM splints, where it's it's aluminum covered by soft material that you can mold and put in different angles and whatever. And then we have traction splints, which are used only for femur fractures. So in this picture on the left at the bottom, that's a type of a traction splint. This one's a bipolar, 2 poles, more commonly known as a hair traction. Above that in the orange is a vacuum splint. There's a pump there to suck air out of this. Once you've applied this to your patient with straps, then you suck the air out and it just goes down on them and holds them in place. The blue thing is a backboard that we could use for whole body splint if we needed it. We've got rolled up blankets here that you can use as a splint. Anything, you can use almost anything as a splint. If you have a forearm injury, I mean, you could take a magazine, wrap it around the forearm and tape it together, and you've started your splint. You know, just have to do something to keep the elbow from moving. Put it in a sling or something like that. Orange stuff on more towards the right here, those are padded board splints. On the far right is a unipolar traction splint, more commonly known as a Sager traction. Again, traction splints are only used for mid-shaft femur fractures. If it's a fracture of the femur really close to the hip, we don't use it. Okay, if it's really close to the knee, we don't use it. It's only for the ones that are in the middle, more towards the middle. Okay, and you're going to be playing with these things. So care for life-threatening problems first. Always expose the injury site. Assess distal PMS or CSM. Align the long bones as close as you can to anatomical position. And do not push bones back in if they're out. Leave them out. You're going to dress them with sterile dressing. You're going to mobilize both the injury site and the adjacent joints above and below. You're going to have to choose a splint. You're going to have to make a decision. We're going to have you play with several different ones. And again, it's more than one way to skin a cat. But whatever you do, it's got to meet the principles. Okay. And try to apply it before you move them to a stretcher or something else. Unless you have, you know, you're in the go mode. You can splint on the way to the hospital. We just don't want you to take time splinting and delaying on scene time if you have a patient with a serious problem. Okay, you can splint on the way. Pad voids. When we put a splint on somebody, we have natural hollows like behind our knees. If we're going to splint this, okay, there's going to be a hollow here. If I put a board here, there's a hollow space. So you want to put something in here so it doesn't make it so it wants to move. So that's what we call padding voids. It's the same for backboarding if you're going to leave somebody on a board, which we don't hardly do anymore. We'll talk about that next lecture. Hazards, again, splinting somebody to death. We talked about that ad nauseum. So you're not ensuring the ABCs. Again, too tight, compressing soft tissues, decreasing blood flow distal to that splint, perhaps interfering with nerve function distal to the splint. Too loose, still allows the bones to move. Okay. Another hazard is, oh, I don't want to straighten that out, so I'll just splint them the way they are. Okay, that's not a good thing, not good for the patient. Standard precautions, expose the area, manually stabilize. So you or your partner, somebody's got to, okay, let's hold this still now. The nice thing is humans are self-splinting animals, okay? We're not like a deer with a broken leg that still runs and that leg is flopping around, right? We go, no, it hurts. I don't want to, you know, I'm self-splinting right now, you know? But when we go up to see them, we need to manually stabilize it while we assess, do our PMS checks, that sort of thing, and up until we have a splint applied to that, unless we have life threats, of course. So, assessing distal functions, realign it again. So this is redundant. A lot of the splints you're going to have to measure. So if you have one of those SAM splints, the moldable splint, the aluminum with all that stuff, you know, they start out being this long. Maybe you're going to fold them over and you got to roll some edges, do some contours, measure that up against the non-affected arm or leg or whatever. So you got the right size so that when you go to apply it to your patient, you don't have to like take it back off and open something up. Once you start playing with it, it'll make more sense. Get it into position, secure it, excuse me, make sure it's functioning the way we want it to do with our principles. Okay. And again, when you're done, reassess. So this is a SAM splint. Okay, and you can see how they've rolled it up under that patient's hand there. Okay, so that gives them something to grasp so their fingers are in a position of function. We call it a position of function. If we splint somebody straight out, and let's say they have to stay like that way for several hours because the ER is busy and they can't get to them, especially if it's an older person, when they finally come out of that splint, they're not able to move their fingers very well. Okay, position of function. And then padding voids as necessary. So you're going to apply this orange and blue thing And then we have to do some way to secure it to that extremity. And here they're using gauze, okay, roller gauze. Theoretically, you could use tape. I wouldn't want tape on somebody's skin though, but theoretically you could. Just real quick for the traction splint, it's for midshaft femur fractures. What it does is, both of these devices, whether it's the 2-pole or the 1-pole, we apply something called an ankle hitch to the foot and ankle. And the upper part of the splint is seated, if it's the hair, in the crease of the butt. And if it's the Sager one, the 1-pole one, it's up in the side of the groin. And we strap those areas. Then with that ankle hitch on the distal end, we apply traction. And we have a crank, basically, that pulls on that leg. And what happens with a femur fracture, because that's the biggest, longest, strongest, heaviest bone in the body, and has a lot of muscle around it. When that thing breaks, those muscles are spasming, and the bone ends are doing this constantly because they're huge muscle bellies, okay? And so by pulling traction, we relieve a lot of that spasm. And so that's going to reduce soft tissue damage, okay? It's also going to relieve pain for the patient. We don't have to put it back into alignment, okay? We just want to relieve some of that spasm and reduce the patient's pain, okay? So again, there's the hair type, which is the 2-pole type, and then the Sager type, which is the 1-pole type. So the amount of traction applied should be roughly 10% of the patient's body weight. That's primarily for the Sager. The maximum is 16. There's a gauge on the crank on the 1-pole Sager that you can go to, and don't go past 16, okay? When it comes to the 2-pole hair splint, then we go by when the patient feels some relief. Okay, then we can stop the crank, okay, and then finish strapping the leg to the device. Sometimes I've seen this on test questions too. What's the maximum, pounds of traction can you use with a Sager type splint? That's 16, but the norm is 10% of the patient's body weight if they're less than 160 pounds. Again, standard precautions. Hopefully your femur didn't go open, because if it did, that's really bad. You're going to stabilize, manually stabilize, just like you would any other fracture. Assess the distal signs, adjust the splint compared to the good leg, then to apply it to the bad leg. Okay. And it's a bit of a process. Here's an example. Somebody's holding traction, their manual stabilization, if you will. He's sizing up that bipolar or hair type of splint with the good leg. That blue pad by the EMT on the right's right elbow, that's going to go up in the crease of his butt, okay, between the back of his thigh and where the butt crease is. That sits it in there. And then there's a strap that goes around the top of the leg to hold that steady. Down at the very bottom of that bipolar splint, you can see the ratchet, crank device, if you will. And there'll be an ankle hitch put on that person's ankle, and they'll attach it to a hook at that distal end of that splint, and then they'll start cranking down traction. It'll stay in place because it's been seated up in the crease of their butt, right? Once the patient feels relief, we stop the crank, and then the straps that are in the middle there get put around the leg to hold it still. All right, some specific injuries. Shoulder and humerus, basically for shoulder dislocations or AC separations, which is acromioclavicular. Clavicular meaning clavicle, collarbone, and acromion is the process of the shoulder blade, the scapula that comes up and meets that area, and that clavicle will pop up. So when you're assessing your patient, how do you tell the difference between an AC separation and a shoulder dislocation? When you're palpating, you can feel the end of the clavicle sticking up. Shoulder dislocation, remember the ball is going to be down here. So that's how you tell the difference. Either way, do you have to diagnose which one it is? No, you don't. Either way, you're going to treat it the same way. You're going to immobilize them. And we use a sling and a swath. So if it's a shoulder, we're going to put them in a sling. So that's going to hold their elbow still. And then we're going to put a swath all the way around them to keep their shoulder from moving. So that immobilizes the site, the shoulder, and the joint below the elbow. Okay. If it's a humerus fracture somewhere in here, the same thing will work, but you can also put a board splint or a SAM splint, one of those multiple splints on here. You don't have to, but sling and a swath will work for a humerus fracture because you're immobilizing the shoulder, immobilizing the elbow. It shouldn't be moving around. If it's really unstable, put a board splint on there along with the sling and the swath. Pelvic fractures are particularly nasty. It's sort of femur fractures. If they're an unstable femur or a pelvis fracture, they have a chance to have a lot of bleeding. Okay, the femur and the pelvis are hard bones to break because they're big, and when they break, that means a lot of force has been put on them, and so those aren't good things. For a suspected pelvic fracture, and again, if the patient has a mechanism of injury and they say it hurts, my pelvis hurts, we don't palpate them. Okay. If in the process of palpating a patient, they didn't say their pelvis hurts and they go, ouch, okay, then that's an issue. That's a real concern. You got to really watch that patient because they could be bleeding internally and there's no way to stop it. But what we can do is put on a pelvic binder or a pelvic sling, which is just simply, you could even, there's commercial ones that you can use. It's like a big belt that goes around the pelvis type of thing. And you can make one with a sheet. I think I got a picture of one here too. Hip fractures, again, what do we look for? We look for that shortening and external rotation, okay? And for those, we can splint them with pillows. We put pillows underneath their knee. Their knees are going to be up quite often because of the rotation, it makes their knee come up. So we're going to put a pillow under there or a blanket under there, something like that, and then tie their legs together. So the one leg is splinting the other leg, and that keeps the hips from moving, okay? And then we can put them on a backboard or a scoop stretcher, something like that. I know we haven't talked about moving devices yet, but we're doing that later. So this is an example of somebody using a sheet as a pelvic binder, okay? All right, so I'm going to show you a few x-rays here before we're done. This first one is an ankle dislocation. So these are old x-rays that I had back in, not me, but people I worked on when back in the days when I worked ER, first was on an ambulance, was able to acquire them. Hopefully you can see my cursor, but the big bone in the center that goes up, that's the tibia. And the flat part at the bottom of that is supposed to be on the flat part of this tarsal bone, okay? So it's dislocated. The other thing, if you look closely, here's the fibula coming down. Again, remember the fibula, as I mentioned a couple weeks ago, is not attached to the femur like the tibia is, you know, with cartilage in between and ligaments. It's attached to the side of the tibia, about an inch below that joint. If you look closely, you can see this comes down here and then boom, it broke off the end of this fibula. So this is a fracture dislocation, just combination fracture and dislocation. This next one is a dislocated wrist. So here's the thumb, and on the right side, the bigger bone on the right going down is the radius bone, and it's shoved up. This bone between these two long bones that you see down here, in between them, that's where the radius is supposed to be, down there. And it's not, it's way up. So both of these bones, the ulna and the radius, have dislocated and moved distally, okay? This next one is a fractured wrist. And you can see how sharp the bone end is. Okay, it's easy to see why broken bones can damage soft tissues. You know, whether it's, you know, skin, muscle, nerve, blood vessel, whatever, okay? Sharp bone ends. The next picture is a comminuted fracture. Remember, comminuted meant pieces, normally from a crushing type injury. This was somebody that was between two cars. The femur is at the top and everything is broken below it. Okay, you can see shards of bone on both the right and the left. There's a big long shard on the left towards the bottom there. Okay. Big time bad, because Lord knows what's happened to blood vessels and nerves and things like that in that area, ligaments, you name it. The next one is a comminuted femur fracture. This particular person, this one still kills me, I was on the call. This is a person that has a pre-existing bone disease and has had multiple fractures in the past. For whatever reason, they have weak bones. I don't remember what the name of the disease was. We're talking 30 years ago. This person was riding a motorcycle and got in a wreck. You know, if you had bad bones and you broke at a moment's notice, would you be out riding a motorcycle? I don't know. But look at all the damage to that bone, and you can imagine what's happened to the soft tissues around it. A lot of damage, a lot of damage, and very hard to repair. You have to try to put all those pieces together, put rods and screws in, and you name it. This next picture I affectionately call the mailman, because it looks like this is his foot and lower leg, and it looks like a dog took a chunk out of his leg. So I call it the mailman. But what it is, it's obviously a big fracture. It was an open fracture. His foot, when I got there, was actually turned around backwards. All of this diamond looking stuff on the left is a splint, a plastic splint that shows up on x-ray. But big time bad. This person lost the blood vessels coming down his leg, going to his foot. He ended up having an amputation. But a lot of bone missing here, blood vessels missing, nerve missing. The fibula is also broke. It's hard to see. I don't know if you can see my cursor or not. If it shows up on the display. But there's the fibula broken part here. You can just see the step off there. Okay. This next one is a pelvis fracture. And I did my little sign here thing to point it out. If you look on the left side of your screen, the inside of the ilium going towards the ischium bone in the pelvis, it's nice and smooth. It kind of goes around the bend there, looks nice. On this side, it comes around and oops, it's not nice and smooth anymore, it's broke, okay? And so is the socket. Now, this type of a fracture, again, we joke around in medicine sometimes, but we call this a fractured ass because the socket where the head of the femur fits into the pelvis is called the acetabulum, A-C-E, tabulum. And so when they break that, we call it a fractured ass. Now, the one thing about a pelvic fracture and quite often a lower leg and lower arm fracture is it's like a donut. Okay, the pelvis is like a donut, and it's hard to break a donut in one spot. They usually break in two spots, okay, because you're breaking it apart. So in this case, we have a big nasty fracture here. Obviously, there's going to be a lot of bleeding and big time bad. Now, this funky looking thing coming up from the bottom in the center, that's a urinary catheter. So this person has a catheter into their urinary bladder. But what I want you to look at is down at the bottom where that first comes up off the bottom of the picture. If you look to the right, you can see where the rim of the ischium comes down and into the pubis area. But then look on the left, it's lower. Okay, there's quite a difference here. And that's the second fracture area. So our donut got broken over here where I've got the pointer, and very down at the bottom, you see they're not lined up. They should be lined up. They should be totally across from each other. Okay. So pelvic fractures, that's why they're nasty. Quite often they break in a couple places, so you get a lot of bleeding. Okay. The next one is a green stick. This is an obvious green stick on x-ray, but again, on a lot of x-rays I've seen, they're not obvious. There might be a little tiny bump. But again, pliable bones in a child, okay, they fray, okay? The fracture does not go all the way through. If this went all the way through, that would be a transverse fracture, okay? It doesn't go all the way through, so it's called a green stick. Now, up at the top, remember I talked about, now down here where the fracture is, this is the diaphysis, the middle part of the bone. Up in here, where it comes up towards the end, we call the metaphysis, and here's the epiphysis. Now see here, this is the growth plate. these two parts of the bone are not totally touching each other. There's bone being formed in between in that gap. And that's where those epiphyseal fractures will occur. So again, this child is not done growing. When you take an x-ray and they have an epiphysis like this, it means they're still growing, okay? So again, epiphysis, metaphysis, and then diaphysis. The next picture is a pretty cool one I like. This is a humerus, upper arm bone. This is somebody that had already broken the bone, was starting to heal, and then they fell again and refractured it, if you will. The nice thing about this one is there's a little bit of an angulation. That's not a big deal because the body would smooth it out later. You can see just to the right of the fracture, where should be obvious where the fracture is, the shadow there. It looks like a line that goes up and over it and goes down around the bone. That's the periosteum, where the new bone is starting to be deposited in. Okay, and that's where I said the periosteum will grow and go over the top of that blood clot, and then the bone cells start going in there to regenerate. If you look totally across from that, you can actually see where bone was starting to fill in this angle, that haziness, directly across from where the fracture was. So towards the lower left, if you will. All this stuff in the background is a splint again. So this one shows you the healing nature of bone because you can see the periosteum and you can see the cloudiness here where bone is being deposited on this side. Again, we're taking a three-dimensional object and taking an x-ray and making it two-dimensional. So that's why quite often when you have x-rays, they take 3 views to try to see all the way around something, okay? Because it's hard to imagine, but this new bone growth is also happening on the backside where we can't see it. Basically, we could on another view of an x-ray. But I like this one because it shows the periosteum and it kind of really shows folks what we were talking about with the healing nature of bone. And it's starting to get hazy in here where it was starting to heal, but now they re-injured it. So those are some films just to kind of give you an idea of what we're talking about. Obviously, we don't have x-ray vision. We're not going to know this is what's happening, but the more knowledge you have, the better prepared you will be to take care of patients. So remember, bones, joints, muscles, cartilage, tendons, ligaments, that all makes up the musculoskeletal system. Okay, remember the physiology, what it does for us. Okay. So fractures, dislocations, sprains, strains, those are the injuries. And remember the forces that cause them. Okay, direct force, direct impact, usually a blunt trauma. Or it could be penetrating trauma that goes in and breaks a bone, you know, gunshot wound or stab wound or something like that. Indirect force, they landed in one spot, but the fracture happened in a different spot. It just transmitted the force until it hit a weak spot and caused the fracture. Then the twisting or rotational forces that can cause those spiral type fractures. You have to remember the principles of splinting. That has to immobilize the site, the joint above, joint below, and you do your distal checks before and after any procedure. Splint should be in a position of function, and make sure you're padding voids to make that a comfortable splint for your patient. Remember, closed extremity is one where the skin has not been broken. An open fracture is one where the skin has been broken. Remember that pelvic fractures and femur fractures may indicate more severe injuries. So again, it takes a lot of force to break those bones. So if there was that much force imparted on the body and broke those bones, there's probably soft tissue damage inside. You could have organ damage, you know, could be something like a liver laceration or spleen rupture or something like that. You got to keep a close eye on these people, okay? You're gonna learn different techniques for mobilizing injuries, but again, one of the traits that we discussed early on for an EMT was to be resourceful. And that's the whole, I can teach you how to splint, I can teach you how to bandage, I can teach you how to backboard, teach you how to manage airways, but I can't tell you how you're gonna do that in that car that's upside down in the ditch and the water's rising. That's something you're gonna have to figure out when you get out there, okay? And that comes with experience, okay? 3 phases of your training, okay? The stuff we teach you in lecture, the stuff we teach you in practice time, and the stuff you learn once you get out on the streets and start taking care of patients. Okay, when you come out of the class, you're not going to be a good EMT. You're going to be entry level EMT. You need to keep at it to become a good EMT. All right, so we've now covered soft tissue injuries, shock, and musculoskeletal injuries. Next, in the final lecture in the trauma series will be head, neck, and spine injuries. We'll be doing that as live Zoom at this point. And that's all I have for tonight. Hopefully this was not too boring for you. But the trauma stuff is the fun stuff, okay? We're adrenaline junkies and we like dealing with injuries and trying to make people better. So that's all we have for now. So we'll see you soon. Have a great day.